Okay, let's see if I can beat my time. I was 26 minutes on that last video, so I'll try to keep this one short. A lot of it we covered in that first chapter is kind of going to be a repeat as some signs and symptoms, but some things are new, so. Okay. And I uploaded all of these PowerPoints for you guys as well in the green book. Okay, so head injuries. We're going to talk about different types of head injuries. It's a pretty broad category, but it could be injuries to the scalp, skull, or the brain. This is the most common cause of death from trauma. And the most common cause of brain trauma is falls. And that's not surprising, is it? So we have a primary injury, which is the consequence of direct contact with the head and the brain during an injury. So contusions, lacerations, external hematomas, skull fractures, concussions. And we have a secondary injury, and this damage occurs over several days or hours after initial injury from secondary cerebral edema, tissue ischemia, or chemical changes related to the trauma that affect the brain. So let's talk about some different types of injuries here. So scalp wounds, the manifestations are going to depend on the severity and the location. The scalp wounds, they tend to bleed a lot and people really, really freak out, which inevitably so, because you just see like large copious amounts of blood. But the scalp is very vascular, so these injuries are going to bleed a lot and are portals for infection. So. And then we have skull fractures. There's different types of skull fractures here. There's a linear fracture and a depressed fracture. So this goes across, and this is like a depression of a portion of the skull. And then we have a basilar fracture. So the basilar fracture is actually at the base of the skull. And a sign of a basilar fracture is actually this right here, and this is called a battle sign. And this is bruising over the mastoid area, and that results from that fracture right there at the base of the skull, this basilar area of the skull. Whoops, sorry. So this is called a battle sign. So you'll see that bruising or ecchymosis around the mastoid. You may also see, depending on where the fracture is, but you may also see drainage of cerebrospinal fluid from the ears or the nose, which is not good. So nursing management is somebody with a skull fracture these injuries to the head. We want to always assume that the cervical spine has been injured until that's been ruled out. So like in the field, you never want to move someone until you have them positioned and immobilized to protect their C-spine, their cervical spine. So that typically means putting them on a backboard and in a C-collar, cervical collar, that keeps the neck rigid, because if there is damage to those cervical vertebrae, it can cause complete injury to the spinal cord, which we'll talk a little bit about more. But we want to always assume with these injuries that there could be a spinal cord injury. We want to treat cerebral edema if there's cerebral edema going on, which we've talked about in our previous chapter, so I'm not going to go into that again. We want to maintain cerebral perfusion, treat hypotension, hypovolemia, bleeding. We want to monitor our intracranial pressure. And what did we say that needed to be? Go back and look at your notes on what a normal intracranial pressure is. We want respiratory support, so especially if the injury is a little bit higher, which we'll talk more about with spinal cord. Any type of brain injury, seizure precautions and prevention, fluid and electrolyte maintenance, those type of things. So these are typically considered mild, just depending on how severe the skull fracture is, but mild traumatic brain injuries. Manifestations of a brain injury, obviously we could have altered level of consciousness. We see changes in our pupils, and that is related to our intracranial pressure, like we've talked about before. Neurodeficits, changes in vital signs, headaches, seizures, all those things we've pretty much talked about in the one video that I posted that was an hour long. So I'm not going to go over it again. Different types of injuries. We have a closed brain injury, which is a blunt trauma. So this is where basically your brain bobbles around in your head. So you've either hit your head or you've had like a acceleration, deceleration, and your brain's rattling around in there, right? So that's a closed brain injury. This is typically the worst and most severe. And then we have the open brain injury, and this is basically where we have an object penetrate the brain, and it's so severe that it penetrates through. This is going to be obviously at a higher risk for infection too, because we have something from outside inside the brain. So risk for infection, wait for bacteria to get in. We have contusions. This is a more severe injury with possible surface hemorrhage. Your contusion is basically a bruise, right? Symptoms and recovery depend on the amount and the damage and the associated cerebral edema that we have with this. With a contusion, they may have a longer period of unconsciousness with more symptoms of neurologic deficits and change in vital sign versus concussion. 80% of traumatic brain injuries are concussions, and they usually occur from blunt trauma, and the symptoms are going to depend on the location of the concussion. Observation of patients after head trauma. We want to observe for changes in level of consciousness again. They may become difficult to wake or lethargic, dizziness. The patient should be aroused and assessed frequently. We don't want to just let them sleep, right? Because then we're not able to assess if they're having changes in their LOC if we're not going in and waking them up and assessing them. Difficulty in speaking or movement, severe headache, vomiting. Those are all signs we want to watch for. Epidural hematoma. This is blood collection in the space between the skull and the dura, and I've got a picture on the next slide that really can show you guys what it looks like, but this is an emergency situation. So right here you have the epidural hematoma, and this is the collection of space in between the skull and the dura, right? And then we have a subdural hematoma, and this is where we have a collection of blood between the dura and the brain. So an epidural hematoma is a medical emergency. An extreme emergency, we can have marked neurologic deficit or even respiratory arrest occur within minutes. So this has to be treated immediately. Typically, patients will have a brief loss of consciousness with return to a lucid state, and then as the hematoma expands, they're going to have that increased intracranial pressure and a sudden decrease in LOC. Treatment includes measures to reduce the intracranial pressure, remove the clots, stop the bleeding. When we talked about that surgery in the first chapter, I talked about 66, where they go in and they drill the burr holes and evacuate a clot. This is what we're treating. We're treating that epidural hematoma. Patients will need monitoring and support of vitals, respiratory support. I mean, they'll need to be in an intensive care unit, probably a neuro unit. Chronic, and then we have the subdural hematomas, and those can be acute or chronic. So an acute develops within 24 to 48 hours, and the signs and symptoms include our level of consciousness changes. We have some pupillary signs. We can have that hemoperiasis, and that occurs as our ICP increases. It can progress to our increase in blood pressure, decreased heart rate, and breathing issues. So remember, we call that the Cushing's triad. So as we have more increased intracranial pressure, we have a higher blood pressure with a widening pulse range. We have that decreased heart rate because of the stimulus to the vagus nerve, and then the difficulties with the breathing because of the pressure on the brainstem. So that is your sign of increased intracranial pressure that's getting markedly worse. This is going to require immediate craniotomy and control. So again, we would need to get in and evacuate that clot. Versus chronic can develop over weeks to months. We may not even have thought, oh, I hit my head that hard, and the symptoms don't come on right away. They can come on over time, and they can fluctuate. So again, the treatment for this would be evacuation of the clot. The nursing process and the care of somebody who has a brain injury. So we want to get a health history that focuses on the immediate injury, what occurred, the time, the cause, what the direction of the force was, how, did they become unconscious? Did they keep a lucid state? Everything that happened, we need to get a detailed history of. And then, of course, our level of consciousness, we're going to use our Glasgow Coma Scale, and I've already talked about that in the first lecture, so I'm not going to cover it again. There's also a really good video on a nurse that does a Glasgow Coma Scale that I've posted, so I want you guys to know and be familiar and have down how to do a Glasgow Coma Scale assessment. That is a must. You need to know that. We're going to do frequent and ongoing neurological assessments. One of the most important nursing goals with a head injury is obviously maintaining our airway and ventilation. So airway and breathing is always going to be in the forefront, and we've talked about this again. So to relieve intracranial pressure, positioning that we can do is head of the bed 30 degrees, right, and maintain that neutral neck alignment and not have increased abdominal pressure. That increases intracranial pressure. So Valsalva maneuver, coughing, flexion of the hips, those type of things. We talked about that in detail in the first chapter. Remember our change in vital signs. So as our blood pressure goes up, our pulse pressure widens. We have bradycardia because of pressure on the vagus nerve. So we're monitoring our vital signs for those changes, right? Temperature regulation, hypothermia. When we have injuries to certain parts of the brain, then it can cause our temperature to be dysregulated. The cerebral edema is the most common cause of increased intracranial pressure in someone with a head injury, with the swelling peaking around 48 to 72 hours after the injury. So we need to remember our interventions that can control ICP. So like we said, elevate the head of the bed at 30 degrees, that neutral neck alignment, preventing abdominal pressure, maintaining our O2 sats, and our cerebral perfusion pressure between 50 and 70. Patients with head injury are at increased risk for post-traumatic seizures, and that can be treated with anticonvulsants. Spinal cord injury is the last thing we're going to talk about here. Spinal cord injury is the major cause of disability in the United States, and it affects 80% of these people that affects are males. It usually results in a concussion, contusion, or a laceration or compression on the spinal cord. So there's varying degrees of injury on the spinal cord, depending on the severity of the injury and, of course, at what level on the spine it occurred. Primary injury results in trauma and is usually permanent. The secondary injury, again, just like when we talked about in the beginning, the secondary injury is not actually the injury to the cord itself, but edema and hemorrhage around the cord from a trauma. A complete spinal cord lesion signifies loss of both sensory and voluntary motor communication from the brain to the periphery. And this is going to result in paraplegia, which is both legs being affected, and quadriplegia, which is loss of movement to all four limbs in the torso. So right here you can see C4 injuries and above. That's why we're talking about being so careful and protecting that cervical spine, because C4 or above can cause paralysis of the diaphragm. So that's, if we have paralysis of the diaphragm, what happens? We can't breathe. So it's really important to support that. And if somebody does have a C4 or above, they're going to need to be on ventilator support because they're not going to be able to breathe themselves. So just depending on the level of injury is where our motor function is going to be. Spinal shock versus neurogenic shock. So spinal shock affects just the spinal cord. And this, again, can happen anywhere on the spine. And this is tissue damage in the area of the injury results in a release of a chemical mediator that causes vasoconstriction. and this leads to spinal cord ischemia and hypoxia. So if we have ischemia and hypoxia, then we're going to have this flaccid paralysis, right? So we have that's what's called spinal shock. And this is going to occur at the level below the injury site. So, you know, if it happened at T2, your spinal shock is going to occur below that level of the injury. And then your neurogenic shock affects your entire nervous system versus your spinal shock just affecting your spinal cord. So your entire nervous system is affected with a neurogenic shock. And this usually occurs with high level of injury on the spine. So a T6 or above is usually indicative of what you're going to have is the neurogenic shock. And this is as a spinal cord disruption, we have a loss in our sympathetic nervous stimulation. So remember, our sympathetic nervous system produces our fight or flight hormones, our catecholamines, norepinephrine and epinephrine. And when we have a loss of those, we have trouble maintaining our blood pressure because epi and norepi cause vasoconstriction and help us maintain our blood pressure. So we're going to have hypotension and severe bradycardia and neurogenic shock because we've lost our fight or flight hormones, basically. And so what can cause that is that injury above that T6, and it causes that to affect the entire nervous system and not just the spinal cord. And then we have autonomic dysreflexia, and this is an acute emergency. And this is an exaggerated response by the sympathetic nervous system. So here we're talking about that again. So the sympathetic nervous system, we said, was our fight or flight, and it releases our norepinephrine and our epinephrine. And these cause vasoconstriction. And so with autonomic dysreflexia, we have an irritating stimulus below the level of the spinal cord injury. Only those who have had a T6 or higher injury are at risk for this. So what do we normally do when we get a noxious or irritating stimulus? So it's the body's way of saying, hey, there's something that needs to be addressed. And then, you know, it sends a signal and then we know what to do. But when we have an irritating stimulus and we have the spinal cord injury, that signal gets blocked and then it kind of goes haywire, right? So some irritating stimuluses that are notorious with our autonomic dysreflexia are bladder distension, bowels, so constipation and hard impacted stool, and then a breakdown of skin. So a skin injury or pressure injury that is an irritating stimulus. So we have that irritating stimulus so let's say we had a distended bladder. What would normally happen is our body would send a signal and say, hey, your bladder's distended and that's uncomfortable, irritating stimulus, so you need to go empty your bladder. But that signal gets blocked because of the damage on the spinal cord at T6 or higher. It doesn't get sent properly. And so then we have this cascade or this reflex response that leads to release of the fight or flight hormone, basically, and that's going to cause hypertension, severe hypertension, to where your patient can have a stroke, seizures. It can be fatal. So they'll have a throbbing headache, profuse sweating, bradycardia, all these different symptoms, but throbbing headache, hypertension, and profuse sweating are your most common ones, and bradycardia. So nursing interventions, we want to place the patient in a seated position at 90 degrees, because when we have them sit up, then the blood can go down to the lower extremities, and this is going to help lower the blood pressure. We're going to elicit some orthostatic hypotension to try to help get that blood pressure down. You want to do a rapid assessment and find out what is the irritating stimulus. So let's start with the bladder. We want to empty the bladder as soon as possible. If they have a catheter, check for kinks, make sure it's not blocked, make sure it's flowing, irrigate it, or change the catheter out. And then we want to move on and check the rectum do a digital exam. Do you feel a fecal mass? Are they constipated? And then we want to examine the skin and look and see if we have any, skin breakdown going on, new areas of wounds that we are unaware of that could be that irritating stimulus. And then we want to administer an antihypertensive agent like a Presaline through the IV to get that blood pressure down. And then so after they've had this initial, they're going to be at high risk for having this autonomic dysreflexia occur again. So that needs to be in big bold letters for everyone to see, because then we need to know, hey, this person's at risk and we need to be assessing these irritating stimuluses frequently. And then instruct the patient when they go home too, because this is not just a while they're in the hospital thing, but it can happen at home as well. So we want to do education for that. Okay, that is it. That is all I have. Like I said, I posted the lecture videos for all 3 chapters, my PowerPoints, the reading guides, and then there's a video on Glasgow Coma Scale and increased intracranial pressure. That's a really good video that I think you guys should watch. And then I've also assigned 2 HESI case studies, one for seizures and one for stroke. And I'll post those in Moodle as well, so you guys can have a reminder, but those will be due on April, that's my name. March 29th, I believe, is when our Med-Surg Exam 5 is. So you'll have some time to get those done for spring break if you want to. So I went ahead and opened them up early for you guys so you could work on it if you wanted. If y'all have any questions, please let me know. And like I said, we're going to reinforce what we've learned with some learning activities in class. So that's it. That's all I have. Thanks and have a good weekend.